Welcome to Module 2 of Primary Care Migraine, Secondary Headache Disorders in Primary Care, brought to you by the National Headache Foundation. My name is Dr. Merle Diamond. I'm director of the Diamond Headache Clinic in Chicago, Illinois, and it's my pleasure to present this very important module. Here are my conflicts of interest for your review. After completing the CME activity, participants should be able to recognize the red flags that suggest a secondary headache disorder, order the appropriate imaging studies in patients with red flags for secondary headache disorders, know the indications for a lumbar puncture and how to interpret its findings. The definition of a secondary headache disorder is any headache disorder that occurs as a result of another medical condition. This would include hemorrhage, malignancy, or inflammatory conditions that secondarily activate sensory neurons in the head and pericranial structures. On the other hand, primary headache disorders such as migraine, tension headache, and cluster headache are the result of diseases of neurons of the brain and trigeminal nerves themselves. Why care about secondary headache disorders? First of all, there can be morbidity and rarely mortality if a secondary headache disorder is missed. Second, patients care. Some may think they've got a brain tumor and request a diagnostic evaluation, so knowing the risk of a given secondary headache disorder and an appropriate evaluation can often alleviate fear in these patients. Third, there can be societal costs, either from inappropriate use of diagnostic testing or from complications to the patient if an ominous cause of headache is missed. So primary care providers need to know about secondary headache disorders. This table shows some of the more common causes of secondary headache disorders. The column on the left lists the different categories of secondary headache disorders, including neoplastic, infectious, vascular, low and high CSF pressure, trauma, immunologic, and spine pathology. Examples within each category are shown in the column to the right. As can be seen, there are a vast number of diseases that can cause secondary headache disorders. This graphic depicts the risk for secondary headache disorders in primary care. This study utilized a large database of electronic medical records to identify all office visits in which there was a new diagnosis of a headache disorder from a primary care physician. They found that 74% of them received a diagnosis of an undifferentiated headache disorder, which means the physician was uncertain of the specific headache diagnosis. 22% received a diagnosis of primary headache disorder like migraine, cluster, or tension headache. Using diagnostic codes from the database, they identified any secondary headache disorder that occurred up to 1 year after the initial visit to determine the risk of a secondary headache disorder. They found this overall risk for a secondary headache disorder was 2.49% in those receiving an undifferentiated headache diagnosis and 0.95% in those receiving a primary headache disorder. One can conclude from this study the risk of a secondary headache disorder is quite low in primary care. However, if the clinician is uncertain of the headache diagnosis, then the risk increases by 2.5 times. So when do you suspect a secondary headache disorder? As shown on the right part of the slide, it's when there is a new type of headache, and particularly when there are red flags for a secondary headache disorder. If they have had a chronic headache disorder with years with the same headache, then this decreases the likelihood that you're dealing with a secondary headache disorder. This table depicts the SNOOP4 mnemonic, which will help you remember the red flags for secondary headache disorders. If a person has one of these red flags, they will likely need a diagnostic evaluation to exclude these disorders. The S stands for systemic symptoms. This would include unexplained fever or weight loss in a headache patient. It would also include new onset of headache in a person with cancer, HIV, or past transplant. The N stands for neurologic signs or symptoms. This would include neurologic symptoms such as hemiparesis, numbness, and ataxia, as well as an abnormal neurologic examination. The first O stands for onset, referring to sudden onset. The second O stands for older. This indicates a new onset headache in a person greater than 50 years of age. The first P represents progression, which means there has been some change in the past headache disorder. They may present with a different type of headache, or there may be a change in their frequency of headaches. Those with more frequent headaches or those unresponsive to preventive medications may warrant further evaluation. The second P is papilledema, which can be seen in those with intracranial hypertension or brain tumors. The third P is position. If the headaches are worse with standing and better with lying down, then you could be dealing with intracranial hypotension. Conversely, if they are worse lying down and better standing up, then they could be secondary to intracranial hypertension. The final P is precipitated by Valsalva. This would include a worsening with exercise, sexual activity, coughing, or straining. This study determined the predictive value of red flags for secondary headache disorders in the emergency room. The predictors are seen in the left column, and the negative and positive predictive values are shown in the middle and right columns. Note that among the red flags that an abnormal neurologic exam had the highest positive predictive value for a secondary headache disorder. This occurred 44% of the time when an abnormal neurologic exam was encountered. The time course of the headaches can be helpful in determining the cause of a secondary headache disorder. If the headache develops in seconds to minutes, think vascular causes. If it evolves over hours to days, then think infectious causes. Development over weeks to months could indicate inflammatory or neoplastic causes. If it has occurred repeatedly over months to years, think of primary headache disorder. You first want to take an adequate history and physical exam. This was discussed in detail in Module 1, the diagnosis of migraine in primary care. Then you need to exclude secondary headache disorders, as shown on the left-hand part of the slide. If red flags are present, then further diagnostic testing will be indicated to rule in or rule out secondary headache disorders. As shown on the right-hand part of the slide, if red flags are absent, then you would likely diagnose a primary headache disorder. Next, we'll discuss diagnostic testing for secondary headache disorders. This slide depicts a guideline statement developed by a subcommittee of the American Headache Society based on a systematic review of the medical literature. The following recommendation was made by the committee. Neuroimaging is not usually warranted for patients with migraine and a normal neurologic examination. So you don't need to neuroimage patients that have migraine unless it has an atypical feature. The atypical features of migraine that might warrant consideration of neuroimaging: unusual, prolonged, or persistent aura. This means that the aura symptoms were atypical or lasting longer than an hour. Increasing frequency, severity, or change in migraine clinical features, first or worst migraine, and migraine with brainstem aura. These are migraines that are preceded by aura symptoms that occur in the brainstem, such as dysarthria, vertigo, diplopia, and ataxia. Which test to order? We will first discuss the non-contrast CT scan of the head. This is often used in the emergency room to identify hemorrhage in the brain, such as subarachnoid hemorrhage, as well as subdural and epidural hematomas. It also is excellent to visualize bony abnormalities that are seen with osteomyelitis of the skull. The next imaging study that we will review is the non-contrast MRI of the head. This is the test of choice in most situations to rule out a secondary headache disorder. In fact, the American Headache Society has recommended an MRI over a CT scan for the evaluation of persons with subacute and chronic headache disorders that require neuroimaging. It can identify malignancy, stroke, and Chiari malformations. An MRI with contrast is used when you are considering very specific headache disorders, such as low-pressure headache syndromes, meningeal carcinomatosis, encephalitis, and brain abscess. It should also be utilized in a person with known systemic cancer to exclude metastatic disease. It is more sensitive for picking up small metastases than a non-contrast MRI. An MRV is used for diseases involving the dural sinuses. It can be used to rule out dural venous thrombosis or to identify stenosis of the transverse sinuses that can be encountered in idiopathic intracranial hypertension. And then finally, if you're worried about saccular aneurysms or arterial dissections or a disorder called reversible cerebral vasoconstriction syndrome, which we'll talk about, then an MRA or CTA or even sometimes a digital subtraction angiogram would be indicated. A lumbar puncture is performed when you have suspicion for certain diseases such as meningitis, subarachnoid hemorrhage, idiopathic intracranial hypertension, meningeal carcinomatosis, multiple sclerosis, vasculitis, sarcoidosis, and others. We're now going to discuss several case presentations. Each case represents an example of a secondary headache disorder that you may encounter within your primary practice. To make this more interactive, I would ask you to do 3 things when listening to the case. First, think of the secondary headache disorders that should be considered given the clinical presentation. Second, determine which questions should be asked to confirm or refute these diagnoses. And finally, identify the red flags and the appropriate diagnostic work appropriate for that red flag. The first case is entitled Severe Headache of Recent Onset. This is a 35-year-old male patient with a history of migraine who presents with an extremely severe headache that began 2 days ago. In fact, this is one of the worst of his life. It is located in the bilateral occipital region and has some migraine-associated symptoms such as nausea, photophobia, and phonophobia. His neurologic exam in your office was completely normal. So you have to go through a logical sequence of questions to come up with this correct diagnosis. Your first thought might be that this patient is having a migraine. It is a severe headache and the headache has migraine-associated symptoms. So a reasonable first question to the patient might be the following. Is this headache different from past headaches? The patient responds, this is totally different. It is more severe and in a different location. So you are thinking that a secondary headache disorder is possible. Your next diagnostic consideration might be a vascular event such as subarachnoid hemorrhage, intracerebral bleed, or stroke. After all, this is one of the worst headaches this patient has ever had. So you might ask, did the headache have a sudden onset? And how fast did the headache reach peak intensity? The patient says, yes, it reached peak intensity within 45 seconds. So now you are concerned that the patient could have had a vascular event. So you might follow that question up about neurologic symptoms. Do you have hemiparesis, numbness, slurred speech, double vision, vertigo, anything else with this headache? And the patient responds no. You might also think about infectious causes such as meningitis or sinusitis. You might ask, do you have any fever, chills, sweats, pain over your sinuses, or discolored nasal drainage? The patient does not have any of these symptoms. In this case, the patient had 2 red flags. First, they have a different headache type than their typical migraines, and second, the headache is sudden onset. Not only does this patient have a sudden onset headache, but it meets criteria for a particular type of headache called thunderclap headache. A thunderclap headache is very severe, reaches peak intensity in less than 1 minute, and lasts greater than 5 minutes. So our patient has had a thunderclap headache as their headache peaked within 45 seconds and lasted for 2 days. When one thinks of a thunderclap headache, one often thinks of a subarachnoid hemorrhage. However, there are other diagnoses that can cause thunderclap headache, including carotid dissection, reversible cerebral vasoconstriction syndrome, intracranial hypotension, pituitary apoplexy, and migraine. This represents the suggested management for a thunderclap headache. If the headache has occurred recently, we would recommend sending the patient to the emergency room to rule out subarachnoid hemorrhage. Once in the ER, a non-contrast CT scan of the head would be performed as the initial imaging procedure. The CT has a sensitivity of 95 to 99% for identifying subarachnoid hemorrhage if performed within 6 hours of onset of the thunderclap headache. This has been called the 6-hour CT rule. In fact, the American College of Physicians put out a clinical policy statement in 2019 stating a non-contrast head CT performed within 6 hours after headache onset precludes the need for further diagnostic workup if the CT scan was done with a modern generation CT scanner. Regardless of this recommendation, the decision to forego further testing after a negative CT scan should involve a discussion with the patient weighing its risks and benefits. If this head CT was negative, then the next step would be to perform a lumbar puncture looking for xanthochromia as well as a high red blood cell count in tube 4. Xanthochromia is a yellow hue to the spinal fluid that represents breakdown products of red blood cells. It can be identified by visual inspection of the spinal fluid or by spectrophotometry. In some labs, there is no universally accepted criteria for a high number of RBCs within tube 4. But one study found that a cut point of 2,000 by 106 RBCs per liter had a sensitivity of 100% in excluding subarachnoid hemorrhage. Others will use a declining red blood cell count between tubes 1 and 4 as evidence that it was a traumatic tap rather than a subarachnoid hemorrhage. Even if the CT and lumbar puncture are negative, some will still recommend a CT angiogram or an MR angiogram of the head and neck to exclude other causes of thunderclap headache, such as carotid dissection. Our patient had a negative non-contrast headache CT and lumbar puncture and was discharged from the ER. However, he had an MRA as an outpatient 2 days later that revealed multiple areas of vasoconstriction as shown by the arrows on this slide. This was consistent with a diagnosis called reversible cerebral vasoconstriction syndrome. It is diagnosed when there are 2 or more segments of vasoconstriction within the same artery occurring in more than one artery. This has been increasingly recognized as a cause of thunderclap headache. It's most common in women between the ages of 30 and 50. Predisposing factors for RCVS include vasoconstrictive meds such as decongestants and triptans, use of cocaine and cannabis, pregnancy, and postpartum state, pheochromocytoma, and migraine. Neurologic deficits occur in between 8 to 43%, seizures in 1 to 17%, and subarachnoid hemorrhage in 30 to 40%. The vasospasm noted on imaging may not resolve for 3 months. There is no proven treatment for this syndrome, but calcium channel blockers are often used to reduce the vasospasm. Case number 2 is entitled A Severe Headache with an Abnormal Neurologic Sign or Symptoms. This is a 32-year-old female who complains of a new onset of headache. The headaches are located in the left frontal, retroorbital, and temporal regions. They are severe with a pain intensity of 8 out of 10. They've been daily and continuous for the last 3 weeks. It reached peak intensity 3 hours after onset, so it was not a thunderclap headache. When you ask about neurologic symptoms, she reports complete visual loss of the left eye that has occurred on 2 occasions and lasted for 1 to 2 minutes each time. She stated it was like a curtain pulling down over her left eye. This is consistent with amaurosis fugax. Your physical exam showed ptosis and miosis of the left eye. So this physical finding is consistent with a painful Horner syndrome. So the red flags in this case are the amaurosis and the Horner syndrome. She underwent a CT angiogram of the head and neck and was found to have a carotid dissection. So when do you suspect a carotid dissection? It generally presents with unilateral headache and neck pain. Typically, there are signs of cerebral or retinal ischemia. It can present with amaurosis, TIA, or stroke. As encountered in this case, a painful Horner syndrome strongly suggests the diagnosis. However, a painful Horner's may be seen in up to 58% of cases. This occurs because the enlarged carotid artery compresses sympathetic nerves that surround the carotid artery. Case 3 is one of orthostatic headaches. This is a 32-year-old female with hypermobile EDS who complains of a new onset headache. It is located in the occipital region and occurred 6 weeks ago, immediately after lifting a heavy box. The pain intensity is 8 out of 10. Alleviating factors are laying down. In fact, the only time she gets any relief is when she lays down. She has no neurologic symptom and has a normal physical exam. The red flag in this case is the positional component to her headaches. These are called orthostatic headaches, which are headaches that are worse standing and improve lying down. Generally, lying down will either take the pain away completely or nearly completely. Other symptoms of orthostatic headaches are headaches that worsen throughout the day with more upright time. This can indicate a leak of spinal fluid that occurs from a tear in one of the nerve roots of the spinal nerves. These headaches occur more commonly in those with connective tissue disorders like Ehlers-Danlos or Marfan syndrome. The leaks can occur after a lumbar puncture or spontaneously after straining or lifting a heavy object. The initial diagnostic test to evaluate orthostatic headaches is an MRI of the head with and without contrast. If they have a CSF leak, they will have a dural enhancement with contrast, which is shown by the arrows on the image to the right. The enhancement is secondary to venous engorgement of the dura that occurs because of obstructed venous outflow as a result of the brain sag at the level of the foramen magnum. Other MRI findings include descent of the cerebellar tonsils as shown on the image to the left and a flattening of the pons as shown on the right. Our patient had all three findings: dural enhancement, descent of the cerebellar tonsils, and a flattened pons. She underwent a high-volume blood patch at the T12L1 vertebral level with a complete resolution of her orthostatic headaches. In this case, we gave her a non-targeted blood patch as we did not know the precise location of the leak. Typically, we will perform 2 to 3 non-targeted blood patches before proceeding to myelograms that might identify the exact site of the leak. Once a leak is identified with a targeted blood patch, it can be given at the level of the CSF leak. Case number 4 is entitled Worsening Headaches in an Overweight Patient. This is a 48-year-old female with a long history of migraine who reports worsening headaches of 3 months duration. They are located in the retroorbital and occipital region. The headaches are daily and continuous. She reports some blurred vision and occasional loss of vision in both eyes, particularly when she bends over. Her BMI is 45 and she has a normal neurologic exam. She is noted to have papilledema on fundoscopic examination. With her blurred vision, visual loss, and obesity, you must consider idiopathic intracranial hypertension, which used to be called pseudotumor cerebri. You need to ask questions that are specific for high-pressure headaches, such as, are the headaches worse with bending over, coughing, valsalva, or sneezing? She answers that they are worse with bending over, coughing, and bearing down. You also must rule out secondary headache disorders. Therefore, you need to ask about neurological symptoms, weight loss, and systemic symptoms. These symptoms were negative in this patient. And finally, you need to consider sleep apnea with her morning headaches. So you must ask about snoring and daytime somnolence. She denied these symptoms. She has 3 red flags for a secondary headache disorder: papilledema, as well as headaches worsening by position and valsalva. Given the red flags, you order a non-contrast MRI of the head, which reveals an empty sella, distension of the optic nerve spaces, and flattening of the posterior glove, which are all findings typical for idiopathic intracranial hypertension, or IIH. With a suspicion for IIH, you perform a lumbar puncture and her opening pressure is 35 centimeters. The cell count, protein, and glucose in the fluid are clear. There are diagnostic criteria for IIH. They require all of the following: papilledema, a normal neurologic exam, and the exception of a 6th nerve palsy, normal imaging, and CSF composition and opening pressure that is greater than 25 centimeters. Our patient had all of these criteria. She was placed on acetazolamide and referred to a neuro-ophthalmologist to ensure that she has not experienced visual loss from the IIH, which is one of the most feared complications of this disorder. These are the take-home messages. Learn the red flags for secondary headache disorders. Your choice of diagnostic test depends on the types of headache disorders that you suspect. The diagnosis of secondary headache disorders can and should be made by primary care physicians. If you have any additional questions, please contact the National Headache Foundation at www.headaches.org. Thank you very much.